Alright, now that we've completely read Chapter 28, Immobility, now we're going to test our knowledge and do a little review and see what we know about immobility, if I can speak. Alright, so we talk about a word called disuse atrophy. What do you think that means? Describes the tendency of the cells and tissue to reduce in size and function in response to prolonged activity from a number of different things. So with immobility, what are some of the metabolic changes that happen when you're immobile for a long period of time? So some things that can happen is you're going to have disruptions in normal metabolic function. You're going to have a deficiency in calories and proteins, because usually if you're immobile, you're going to have a decreased appetite. You're also going to have calcium resorption or loss from bone, which kind of sucks. And then you might have impairments of GI functioning as well. What are some of the respiratory changes that may occur when you're immobile? Well, some of the things that may happen is you may get atelectasis, which is collapse of alveoli, or you might get hypostatic pneumonia, which is inflammation of the lung from stasis or pooling of secretion. What are some of the cardiovascular changes that may happen when you're immobile? So some of the things that may happen is you may get orthostatic hypertension. Basically, it's a drop of blood pressure greater than 20 in the systolic or 10 in diastolic, and symptoms of dizziness, lightheadedness, nausea, tachycardia, pallor, or fainting. When the patient changes from supine to standing position, they might also develop a thrombus or a clot, and then as the workload of the heart increases, so does its oxygen consumption. Therefore, the heart works harder and less efficiently during periods of rest. So our cardiac output will basically fall overall. This kind of sucks. What are some of the musculoskeletal changes that occur when you're immobile? Some of the things could be protein breakdown, so you're going to lose muscle, and then you can have skeletal effect wise impaired calcium metabolism and joint abnormalities, so like disuse atrophy, then you can get osteoporosis or a joint contracture, which is an abnormal and possibly permanent condition characterized by fixation in a joint. And another thing you can get particularly is a foot drop, which is the foot is permanently fixed in plantar flexion, which makes it really hard to ambulate. What are some of the urinary elimination changes that happen with immobility? Biggest thing is renal calculi and like calcium stones that lodge in the renal pelvis or pass through the ureters. Which kind of sucks. What are some of the integumentary changes that happen with immobility? Biggest thing here is the pressure ulcers. We got to be real careful when it comes to those. And then some of the psychosocial effects that happen with immobility as well. So there's some nursing assessment questions that you can read. Kind of straightforward, but if you want to read them, you can. Alright, what is range of motion? Basically the maximum amount of movement available at a joint in one of the three planes. You got a sagittal, transverse, or frontal. These are some of the range of motion exercises. I'll go through these slowly if you want to read these. It's a lot. I don't want to do it. I might come back to it later, but we don't know. Alright, what do you think gait means? A particular manner or style of walking. What are some ways you think that we can assess a patient's gait? Observing them entering the room and note speed, stride, and balance. Ask the patient to walk across the room, turn, and come back. Ask the patient to walk heel to toe in a straight line, but this may be difficult with older adults, so make sure you're walking on the patient's side during that walk. Alright, these are some of the physiological hazards of mobility if you want to read this thing. Let you look at it. What are two things that increase the rate of skin breakdown in a patient who's immobilized? Dehydration and edema. What would be some of the assessment findings that indicate pneumonia? Productive cough with greenish yellow sputum, fever, pain on breathing, crackles, wheezing, and dyspnea. So what is the diagnosis of impaired mobility mean? Patient who has some limitation but is not completely immobile. What does the diagnosis of risk for disuse syndrome mean? Patient who is immobile and is at risk for multi-system problems because of inactivity. So what are some of the ways that we can reduce orthostatic hypertension from happening? As soon as they're able to ambulate after surgery, get them up. And then before you actually get them up, get them dangling over the side of the chair so you can get them venous return and muscle tone back into their legs. Help them with that. What are some ways to reduce cardiac workload on an immobile person? Biggest thing we can do is make sure patients don't use the Valsalva maneuver. So like, think about when you're going to the restroom or you're lifting heavy objects, you know how you stop breathing when you lift? Make sure you're breathing during that. If you're not doing that, it'll stop and it'll all of a sudden come back and you could die from it. So when it comes to applying sequential compression devices and elastic stockings, do you think this can be delegated? Yes, it can. However, the nurse determines the size of elastic stockings and assesses the patient's lower extremity for signs and symptoms of DVT or impaired circulation. So what do you think the signs and symptoms of superficial thrombosis would be? Palpable veins and surrounding areas that are tender to the touch, reddened and warm. Temperature elevation edema may or may not be present. What do you think the signs and symptoms of DVT would be? Swollen extremity, pain, warm, cyanotic skin, and temperature elevation. What do we know about the supported Fowlers position? So we know in this position, their head of the bed is elevated 45 to 60 degrees. Patient's knees are slightly elevated without pressure to restrict circulation of the legs. Thing is, though, there are some troubled areas for the patients in this position, so like increased cervical flexion because the pillow at the head is too thick and the head thrusts forward. Extension of the knees allows the patient to slide to the foot of the bed. Pressure on the posterior aspect of the knees, decreasing circulation to the feet. Sternal rotation of the hips. Arms hanging unsupported at the patient's side. Unsupported feet or pressure on the heels. Unprotected pressure points at the sacrum and heels, and increased shearing force on the back and heels when the head of the bed is raised greater than 60 degrees. What do we know about patients in the supine position? So they're resting on their backs. In this position, the relationship of all bodies is essentially the same as in a good standing alignment, except that the body is in the horizontal plane. You can use pillows, trochanter rolls, and hand rolls or arm splints to increase comfort and reduce injury to the skin and musculoskeletal system. Make sure the mattress is firm enough to support the cervical, thoracic, and lumbar vertebrae. Shoulders are supported and the elbows are slightly flexed to control shoulder rotation, but we know there are some trouble areas with this, such as that pillow of the head is too thick, increasing cervical flexion. The head is flat on the mattress. The shoulders are unsupported and internally rotated. The elbows are extended. The thumbs not in opposition to the fingers. The hips externally rotated. Unsupported feet and unprotected pressure points at the occipital region of the head, vertebrae, coccyx, elbows, and heels. What do we know about patients in prone position? Well, they lie face or chest down. Often his or her head is turned to the side, but if a pillow is under the head, it needs to be thin enough to prevent cervical flexion or extension and maintain alignment of the lumbar spine. Placing a pillow under the lower legs prevents dorsiflexion of the ankles and some knee flexion, which promotes relaxation. It's not available. Ankles need to be in dorsiflexion over the end of the mattress, although the prone position is seldom used in practice. But there are some issues with this one, such as like neck hyperextension of the lumbar spine, plantar flexion of the ankles, and unprotected pressure points at the chin, elbows, female breast, hips, knees, and toes. What do we know about patients in the sideline position? Majority of their body weight is on the dependent hip and shoulder. 30-degree lateral position is recommended for patients at risk for pressure ulcers. Trunk alignment needs to be staying as in standing. We know there's some issues here, such as like lateral flexion of the neck, spinal curves out of normal alignment, shoulder and hip joints internally rotated, adducted, or unsupported, lack of foot support, lack of protection for pressure points of the ear, shoulder, anterior iliac spine, trochanter, and ankles, excessive lateral flexion of the spine if the patient has large hips and a pillow is not placed superior to the hips at the waist. What do we know about patients in the Sims position? Most of the weight is on the anterior ilium, humerus, and clavicles. We know there's trouble positions here. Lateral flexion of the neck, internal rotation, adduction, or lack of support to the shoulders and hips, lack of foot support, and lack of protection for pressure points of the ilium, humerus, clavicle, knees, and ankles.